Hello and welcome to this video about the stepwise approach to patient assessment. This video is going to be about 45 minutes long and it's been made in conjunction with Emergency Rescue Solutions at the Oakdale Training and Assessment Academy. My name's Jason Sadler and I make a range of YouTube videos to help you in the pre-hospital emergency care setting. This is one of 3 videos to do with the stepwise approach to patient assessment. This video dealing with the theory behind the mnemonics, which we're going to go on and look at. Video 2 looks at the cardiac arrest patient, and video 3 looks at the conscious patient, although they do become unconscious at the end. As you can see, there are a number of mnemonics to remember as we work our way through this stepwise approach to patient assessment. At the end of this video, I have done 3 pages of glossary for you, which will detail the meaning of each of these. But we're going to work through these in bite-sized chunks. If you need to stop the video at any stage, please do so. I will not be reading every single screen, but I will read most of the material out to you as we go through and giving you additional information. So let's make a start. Our aims. Anyone who works within the pre-hospital environment has the same aims, whether from a first aider, responder, medic, doctor, paramedic, whichever level we're at, we're all trying to do the same things, the 3 P's as it's known. So we're going to try to preserve life, not forgetting your own. We're also going to try to prevent the patient's deterioration, prevent them from worsening. And finally, we always want to promote recovery. As human beings, we always want to do our best to help another. And this is sometimes the problem that we have, that actually we see somebody in need, we see somebody that we could help, and we then just go straight over and try and help them without thinking about what we're actually doing. The more we do this, the better it will become, because we build up that muscle memory. My advice to all of us is we start with an STD. You won't find this one in the books. This is one that I've come up with. And STD is for stop. Whenever the situation changes or you realise it's a new situation, stop. Stop what you're doing, put your kit down and think about what needs to be done. Think about your stepwise approach. Think about your systematic approach. And we'll go through them mnemonics before you do anything else. STD, stop, think, do. And as you're working through the scenario, if you have a change in the environment or with the patient, don't be frightened to stop. Think about what you need to do now and then do it. That stopping time doesn't have to be for long, but just long enough to make sure it's going to be safe for you to continue. So the next mnemonic we look at is SEEN, and this is our dynamic risk assessment, which needs to be continually re-evaluated as the scenario goes on. SEEN is a good mnemonic which starts with safety, thinking about different elements of safety, health and safety, PPE, even things like manual handling. You might even want to include conflict resolution on there as well. From the JR Calc, they state safety. Perform a dynamic risk assessment. Are there any dangers now, or will there be any that become apparent during the incident? This needs to be continually reassessed throughout the incident. Appropriate personal protective equipment should be utilised according to local guidelines. So depending on where you're working and what you're doing, you need to make sure you've got the right PPE for the incident that you're involved in. That leads us on to the cause, thinking about what has caused this patient to be in the situation they're in, or as we refer to as the MOI, the mechanism of injury. Let's have a look at the J.R. Calc's quote on this. The cause, including mechanism of injury, establish the events leading up to the incident. Is this consistent with your findings? So again, all part of our dynamic risk assessment. That links into the environment, and you can see how these will all overlap because they're all one dynamic risk assessment. We're looking for environmental issues which are present or potential. So, from the J.R. Calc, the environment. Are there any environmental factors that need to be taken into consideration? These can include problems with access and egress, weather conditions, or time of day. We then go on to numbers of patients, because you may need to triage your patients, decide who you're going to treat first. You may go to the 1, 2, 3 rule. We'll cover that when we look at the methane shortly. But let's have a look from the J.R. Calc. Numbers of patients establish exactly how many patients there are during the initial assessment of the scene. So working out early on, because generally we can only deal with one patient at a time, so we might need extra help to help with additional patients or extra resources. This may include using the well-known methane mnemonic to declare a major incident, which we'll go on and look at the full methane now. But in most circumstances, it will be dialing 999 and asking for the emergency services. So there's our scene assessment from the J.R. Calc, and what they quote at the end there is the extra resources needed. Additional resources should be mobilised now. These can include additional ambulances, helicopter or senior medical support. Liaise with the major trauma advisor according to local protocols. Just remember, the J.R. Calc is written for those already working within the ambulance service, but many of us adopt the J.R. Calc guidelines to assist with our rescue organisations or pre-hospital medical work that we are offering. So let's take this on to the methane report then. So when we might need that extra help. So thinking about declaring a major incident is quite a big step. And I said we were going to come back to the 1, 2, 3 rule. And this is looking at CBRN, chemical, biological, radiological and nuclear incidents, including explosive environments. If you have one patient who has collapsed, then approach with normal precautions. If you've got 2 collapsed casualties at one location, then that could be unusual. So think potentially about contamination and approach with caution. If you're unsure, then go to step 3. Step 3, if you've got 3 or more patients collapsed, incapacitated, and they're all in one location, then a CBRN is very likely, so do not approach the scene. We use this very much in the terrorist scenario as well. But if you are in an environment where you know the mechanism and you know why you've got 3 incapacitated patients, then you can deal with it as appropriate, ensuring you've got the right PPE. So methane itself is the major incident declared or put on standby, or you could use it for giving your name or your call sign. Give your exact location. think about using things like what 3 words to pinpoint your exact location, or maybe grid references. The type of incident that you're dealing with, so that whoever you're sending this methane report to will know what to expect. Report any hazards which are currently present or potential from the incident. Discuss the access and egress points, because you could have a number of emergency services arriving and they need to make sure they don't all kind of congest, and they probably want to set up a one-way system allowing ambulances to the front so they got easy exit routes to get the patients to hospital. Then we think about the numbers of patients. On here we've got the P1, 2 and 3, sometimes quoted as T1, T2 and T3, but this essentially is our priority patients, so high priority through to the P3, which could be the walking wounded, and dead is dead. Unfortunately, we try to do the most for the most patients, and if they are dead on our triage, then we leave them and move on to the critically ill that we can do something for. And lastly, on the methane is the emergency services already on scene or needed. Not forgetting to detail your speciality of being on scene. So you may be there providing medical cover at a confined space or a water rescue event, and again you can detail what speciality you can bring to this environment to assist. But let's get that extra help on its way now. Then it takes us into our primary survey, which is our patient assessment. So assess and management should proceed in a stepwise manner, and life-threatening injuries should be managed as they are encountered, i.e. do not move on to breathing and circulation until the airway is secure. Every time an intervention has been carried out, reassess the patient using that systematic approach. So we're going to use a stepwise approach. So if we come across a catastrophic hemorrhage, we need to deal with that, and that is potentially the most life-threatening, which we need to deal with quickly, followed by airway problems, then breathing, then circulation, then new onset of disability, and not forgetting expose and examine or environmental issues. So that is the stepwise approach, or the primary survey, that we will follow. Your initial contact with the patient, you're more than likely to follow the AVPU. This is commonly taught from the Resuscitation Council and is quoted within the JR Calc. So AVPU is to do with level of consciousness, and it's also repeated in the disability section of the primary survey. But on your initial contact, introduce yourself, including your grade. So for example, hello, my name's Jason, I'm a medic with the rescue service. So by introducing yourself, you break down those communication barriers and you make sure the patient and others around you are aware of your position or your grade, to make it valid for you being there and providing help to that person. If the patient is alert, if they're awake, we can then move straight on to the presenting complaint. Find out why they need our assistance. So when we first go in there, introduce yourself. If they look at us, if they talk back to us, then we can move on. We'll be looking at that in a couple of slides time, but for now let's imagine they're not alert, they're not awake, so we carry on down our AVPU. So V is for voice. We're going to give them a voice command and we want to see whether they react to it. So something like open your eyes. And whilst we're doing this, we will watch the patient's eyes to see if there's any fluttering of the eyelids. because if there's enough muscle tone to make the eyelids move, then potentially there's enough muscle tone to keep the tongue off the back of the throat to keep the airway open. So we'll be looking at that in the practical video. Then we move on to pain. In the resuscitation council, we are aware that they, quote, shake the shoulders. But on here, I've put to gently tap the shoulders, because again, all we're looking for is fluttering of the eyes to see if there's any muscle tone there. What we don't want to do is make the situation worse. And if potentially that patient has got a cervical spine injury, a C-spine injury, we don't want to be exacerbating that injury whatsoever. If we get no reaction from the patient after talking to them, giving them a voice command, giving them that pain, then we classify them as being unresponsive. If we are faced with an unresponsive patient, we need to consider getting that extra help, but we don't want to be phoning 999 just yet, because we know one of the first questions they always ask us is the patient breathing. So all I'm going to do at this stage is maybe a shout for help, put somebody on standby, somebody ready to make that phone call for me. So as we continue down that primary survey, we've done the AVPU, we're then looking for that catastrophic hemorrhage, then we're going to go into the airway, breathing, circulation, disability, environment, or expose and examine. You might not get all the way down there because you have to deal with each stage at a time, and this is the importance of doing it in a stepwise approach, because the most life-threatening and the most important for us to deal with is first. So if there is a catastrophic hemorrhage, we need to stop it. That may be by putting direct pressure over the bleeding point, making sure you've examined to see exactly what you're dealing with. It may be indirect pressure while somebody else gets an arterial tourniquet proximal to the bleeding point and applies it on there correctly. If there's no catastrophic hemorrhage, then we can move on to the airway. And when we're establishing if there's an airway, whether the airway is open and clear, we'll be using our senses. We'll be looking, we'll be listening, and maybe even feeling. Again, making sure you're wearing the appropriate PPE. Once we have correctly opened the airway, then we can move on to check for breathing. There's no point checking for breathing if the airway is not open and clear. When we check for breathing, we can check for up to 10 seconds, and again we look, listen and feel, and we are seeing if there is breathing and whether that breathing is adequate or not. If there's inadequate breathing, there may be cyanosis present, which is an indication of hypoxia, so they're retaining CO2. We could also count their respiratory rate, making sure it's above 10 rests per minute or below 30. And we're also going to be listening for that agonal breathing, that sign that they may be in cardiac arrest. Now, if the breathing is quiet and normal, we may well leave the patient on their back and we may finish our observations. But if they are gurgling, that may indicate that there's fluid in their airway, and we may want to use postural drainage, may consider suction equipment, and then we may place them into the recovery position. But whilst the breathing is quiet and normal, we could leave the patient in the position we find them, finish off our primary survey, maybe even do our full secondary survey, and then consider whether the recovery position is needed or not. But if we're worried about the airway compromising breathing, then the recovery position is designed to keep the airway open and clear, and we can always continue our observations in that position. But if the patient is not breathing, if they're not breathing normally, if they've got that agonal breathing, then we need to consider they are in cardiac arrest, and we're going to consider starting CPR. So if our patient is not breathing normally. Now, we're going to start that CPR, and this is what the JR Calc quote as being basic life support. So basic life support refers to maintaining airway patency and supporting breathing and circulation without the use of equipment other than a protective device, usually a face mask or a shield. In the pre-hospital environment, basic life support includes the use of a bag, valve and mask and oral pharyngeal airway. With the advent of automated external defibrillators, AEDs, that are simple to use with little training, defibrillation is now considered part of basic life support. So this is the level that we are aiming at during this training. So if we are already in a team and there's a number of us around and we need to start basic life support, what we need to consider, as well as one person getting that emergency services on its way, the rest of the team will create 360-degree access. We are not going to start resuscitation in an area where it can't be continued. If your patient is in water, within a confined space, just in an area that you can't work, let's move the patient and then start the resuscitation attempt. When we then start the CPR, we're going to get into the chest compressions and attach the defibrillator around the person doing the chest compressions. We will adopt a ratio of 30:2, and the person who is above the head may well have some airway adjuncts they can use, such as a nasal pharyngeal airway, an oral pharyngeal airway, and as we mentioned, we're going to be using a bag valve mask attached to oxygen. Whoever's doing those chest compressions will do a maximum of a 2-minute cycle. So in timing with the AED, every time the AED reanalyzes, whoever's doing chest compressions will swap over so somebody fresh starts the new cycle. And don't forget to make room for advanced life support to take place. If we've got a number of people in our team, the traditional way to set up is somebody above the head of the patient who will be looking after the airway, and that is their only job. They will have their bag to their right hand side, usually suction equipment plus the equipment we've just mentioned, and they will take control of that airway. The defibrillator, as quoted by the resuscitation council, will be to the patient's left-hand side. And I would suggest the person at the head has overall control of everything there. It makes the situation run a lot smoother. We can then have somebody knelt at the side of the patient, level with the nipple line, to do good quality chest compressions. And as we said, a maximum of 2 minutes. Somebody else may be there to squeeze the BVM because the 2-person technique for holding the BVM is the gold standard. If you have a 4th person, they will be stood back and they will act as the team leader, overseeing the whole scenario. Each individual operative will have their own job to get on with, and that's all they need to concentrate on. The team leader will coordinate everything and bring it all together. But if you're solo, the BLS will take a slightly different turn. So if you're on your own, the first thing you need to do once you've established a person is not breathing normally is get that extra help. So dialing 999, phoning up, using your radio, whatever it is, whatever system you've got in place, you need to get that extra help. And this comes from the Resuscitation Council, and when they talk about the chain of survival. The first link in the chain is early recognition and call for help. So that's what we need to do. If you've got your AED with you, you will then put your AED on next. before you start the chest compressions. So the AED will take priority over the chest compressions. Only in the team, because there was a number of us, we were able to do chest compressions and put the AED on around them. Remembering, if we're putting an AED on, it must be down to bare skin. Put in the first electric pad just below the right collarbone and the other pad just underneath the left breast, mid-axilla, so right the way round to the side. Whoever is doing chest compressions, make sure you've got the heel of your hand in the center of the patient's chest. So whether that's doing it from the side or from above the head, you're aiming for a depth of 5 to 6 centimeters. To put that into some perspective, the average credit card or ID card is 5.5 centimeters deep. So that would be right in the middle of the depth we're trying to achieve on the adult patient. We're going to work at a speed of between 100 and 120 compressions per minute. So these are the key points from the JR Calc referring to basic life support on an adult. High quality, uninterrupted basic life support is a key determinant in the survival from cardiac arrest. Agonal breathing is common in the early stages of cardiac arrest and should not be confused as a sign of life or circulation. If there are no signs of life, start chest compressions at a rate of 100 to 120 per minute using a ratio of 30 compressions to 2 breaths. Once the airway is secure, now this may be the advanced life support, so it may be an eye gel or an ET tube, not the OPAs that we're talking about. So once the airway is secure, chest compressions should be uninterrupted with ventilations given 8 to 10 times per minute. Avoid hyperventilation. So once every 6 seconds would be good. As soon as an AED is available, switch it on, attach the electrode pads and follow the voice visual prompts. Use of AEDs takes priority over all other aspects of resuscitation. Okay, so carrying on, that would be our cardiac arrest scenario. So we're now starting to think about our conscious patient or our semi-conscious patient or our patient who is breathing normally. So the primary survey should be undertaken for all patients, as this will rapidly identify patients with acute or potential time critical injuries. Actual or potential time critical injuries. Primary survey shouldn't take any longer than 90 seconds, so nice and quick, 60 to 90 seconds, and you always follow that stepwise approach: catastrophic hemorrhage, airway, breathing, circulation, disability, environment. But again, you might not get to those stages. Always document vital signs, preferably as you're going along, so you get them accurately. Do not document on your glove. That is a really poor infection control measure. So make sure you only put gloves on for bodily fluids and change them regularly. When those gloves come off, they go into orange clinical waste or appropriate clinical waste. So get used to writing directly onto a patient report form. Once you've done your primary survey, you can consider a secondary survey. So a secondary survey is a more thorough head-to-toe assessment of the patient. You're looking for more clues that may be other issues that are wrong with a patient and things that you can fix as you go along. A secondary survey should be undertaken following completion of the primary survey. So one follows the other. So this is from the JR Calc. The primary survey should take 60 to 90 seconds for the assessment and follow A, B, C, D approach. Document the vital signs and the time the observations were taken. Assessment and management should proceed in a stepwise manner, and abnormalities should be managed as they are encountered. That is, do not move on to breathing and circulation until the airway is managed. Every time an intervention has been carried out, reassess the patient. So there's the gold standard which we're talking about today and what we're following. So I mentioned earlier about the AVPU, and we said we were going to go in and introduce ourselves and our grade. Hello, my name is Jason, I'm the medic, and we will see whether our patient is alert. And if our patient is alert, if they look at us, if they acknowledge us, we then can establish that they have got an airway, they are breathing, and they have got circulation. Be it there might be problems with them, but they are there at this stage. So we can then find out what their presenting complaint is, or sometimes referred to as complaining of. Find out what the problem is. So we're now looking for the main reason that the patient needs help. Normally, this is a new onset of a new disability, such as pain or a medical condition or an injury, and that's what we're trying to establish. But whatever that new onset of disability is, do not let that distract you from your stepwise approach. If they say, oh, I've hurt my knee, and you go straight to expose and examine, and you've missed out the ABC, you may have been missing vital clues or indications or findings that you had to deal with and would have saved a life. So do not let the disability distract you at this stage. You're aware of it, but still systematically go through your ABC. But you must always get consent before treating your patient, including taking observations. So let's have a look what the JR Calc has to say about consent. Consent in the pre-hospital care. The JR Calc advises that obtaining consent in ways that are lawful and in jurisdiction in which every reader works is fundamental to meeting patients' legal and ethical rights in determining what happens to them and their own bodies. Therefore, it is important to ensure that you have legally valid consent to conduct assessments, treatments, and other interventions and provide care. Consent must be obtained from each patient or their legally valid representative prior to conducting examination, treatment, or providing care. Always get consent. If you are with an unresponsive patient, we can work in the best interest of the patient. So we can assume consent unless there is documentation, an advanced plan or a care plan to tell us otherwise. So when we're thinking about our secondary survey, we are going to repeat that A, B, C, D route again. So the secondary survey. A secondary survey should only commence after the primary survey has been completed, and in critical patients only during transportation. The secondary survey is a more thorough head-to-toe assessment, a survey of the patient. However, it is important to monitor the patient's vital signs during the survey. So those vital signs will be A, B, C, D, E. So we're going to check that the airway is open and clear, and this can include using a pulse oximeter to get an SpO2 reading to check that they're not retaining high levels of CO2 and they've got adequate O2 in their peripheral blood. We're also going to check their breathing rate, their pulse rate, and find out again about that new onset of disability. And then we can look at exposing and examining to do that head to toe. So we're going to follow this stepwise approach system all the way through. So let's look a little bit more detail at this. The SpO2, so using a pulse oximetry, simply goes onto a patient's finger, and a normal reading is 94 to 98%. I will talk about some variations in that in a second, but one big variation is potentially if you are working with a chronic obstructive pulmonary disease patient who has hypoxic drive, and then their normal SpO2 could well be 88 to 92. The normal respiratory rate is between 12 and 20. Just look at this from the JR Calc when they talk about breathing. We should also assess the rate, the depth and quality of respiration. We can grade it between 1 and 5. Grade 1 is a patient not breathing, which we discussed earlier. Grade 2 is someone who's breathing slowly, less than 12 breaths per minute, and we may need to consider using a bag valve or mask to ventilate that patient. Grade 3 is normal breathing between 12 and 20, but we're still checking that depth as well. Grade 4 is fast breathing, where we're going to observe them if it's between 20 and 30. And grade 5 is very fast, above 30. So just remembering, if we've got a unresponsive patient who is hypoxic, identified by cyanosis, and their breathing is less than 10 breaths per minute or greater than 30 breaths per minute and inadequate, we would then use a bag valve and mask attached to oxygen to ventilate the patient every 6 seconds. Again, the 2-person technique is the gold standard. Moving on to circulation, and we will take the pulse rate. Usually we use the radial pulse, so in the forearm, and the average is then 60 to 100 beats per minute. We can also do the capillary bed refill time by pinching the capillary bed for 5 seconds, releasing it, and it should return to its normal colour within 2 seconds. And then probably the most important one is the new onset of a disability. So we will start with that AVPU again, going through that alert, voice, pain, unresponsive, and we can go into a deeper system of the Glasgow Coma Scale. So working out on that score a maximum score of a fully alert patient of being a 15, or a totally unresponsive patient a score of 3. But again, using an aid memoir to work your way through the GCS. We can go back over the mechanism of the injury to see if it aligns to the disability that they're complaining of. If we believe there's neurological deficit, or we're trying to test for symptoms such as a stroke, we might use the FAST. We'll look at facial movement to make sure it's symmetrical. We could do the arm test, looking at the muscular strength. We can do speech by asking them to talk. And sometimes the T is used for test all 3. On other occasions it may be time to call 999. We can also do a Pearl assessment, looking at the pupils. This is often done associated with head injuries. So we're looking at, are the pupils equal? Are the pupils round? And are the pupils reactive to light? Remembering, we can make it dark as well as using an appropriate pen torch to make it light. Don't forget to gain consent, because it could be off-putting if the patient's got a glass eye, or there's another injury that we can't do a pupil assessment. We then have the MSC ×4 motor sensory capillary in all 4 limbs, so you can go through that as a nice quick test. We can also do a pain assessment, and I really like the Socrates that is in the JR Calc, although there's a number of other pain assessments you can do. In essence, anybody that you're assessing will have a pain score, because the pain is always between 0 and 10 for the system we're using. So 0 being no pain at all needs to be documented, and then 10 being the worst it could be. We then look at environmental issues such as their temperature and whether we need to expose and examine to go through our head to toe. I just want to quickly go through the NEWS, because NEWS, the National Early Warning Score, is used a lot in hospitals, but we're talking about the pre-hospital environment. So the standards on the NEWS are slightly different to what the JR Calc quotes. So if we look at the middle column on the NEWS, the 0, that potentially is saying everything's within normal parameters. And on the respiratory rate, they agree with us, 12 to 20 is normal. But if we look at the SpO2, they're actually saying that 96 and above scores a 0. In fact, if they have an SpO2 of 94 or 95, they score a point on the NEWS score, where we would count that as being normal. Also, if we have a quick look at the pulse, we just said that the JR Calc quotes 60 to 100, where on the NEWS score they're suggesting 51 to 90 scores a 0. So it's just being aware of the slight variations. That then brings us on to more questioning, and when we're doing more questioning, we can use the sample, signs and symptoms, allergies, medication, past medical history, last oral intake, and events prior. All of this is trying to help us diagnose what is wrong, not forgetting if we come across an abnormality, we can treat it as we go along. But there's a reason we use a triangle for diagnosing, and we use this in our writing as well. It's because the triangle has got 3 points, and there's 3 different areas we need to establish to try and diagnose. But it's not important that you diagnose, as long as you treat what you see as you go along. So one of the points of that triangle is to find out the history, and that's when you can use sample to help you go through that. And there's a whole range of history elements that we can try and find out about, which might help us. We're also going to use signs. Now, in medical terms, a sign is anything that the medic can sense, anything you can see, anything you can hear, anything you can feel. So if you, and anything you can smell. So if you can sense it, it's classed as a sign. So you may be able to see swelling. You might be able to hear crepitus, the bones rubbing together. You might be able to smell ketoacidosis on their breath, an indication of diabetes. You might be able to feel surgical emphysema. So anything that you can sense is a sign. Anything the patient tells us is a symptom. Obviously, you're not going to get any symptoms from an unresponsive patient, but if they're responsive, anything they tell us, I'm feeling hot, I feel nauseous, I'm feeling lightheaded, I've got a pain score. That will all be a symptom, and it's important that we document the history, the signs, and the symptom. So that sample is first of all for those signs and symptoms, so we can ask nice open questions to establish that. Find out if the patient's got any allergies, which may be to food or medication or substances, may be linked in with the episode today. Find out if they're on any medication, whether that's regular medication prescribed by their GP or they've brought it from the local shop. Find out what their past medical history is, whether this has ever happened to them in the past or whether they've got family history associated with it. Find out about their last oral intake, food and drink, what they've had, when they had it, and whether that's got any links or connections to the episode today. And then we go back to the beginning, back to the mechanism, the events of the history, the events prior, what led up to this happening today. And we are very specific. We want to know about this episode that has happened today. And as we're going along, we're going to be documenting all of this down. So again, this is from the JR Calc about the patient assessment. Although the care of the wide range of medical conditions will be quite specific to the presenting condition, there are general principles of care that apply to most medical cases, regardless of underlying conditions. Again, why it's really important we go through our stepwise systematic approach. In order to gather as much relevant information as possible without delaying care, the accepted format of history taking is as follows. So the JR Calc suggests we start with the presenting complaint, find out why the patient called for help at this time. That moves us straight into the history of the presenting complaint, and we can then take details of when the problem started, any exacerbating factors, and previous similar episodes. We can ask direct questioning about associated symptoms, but we're thinking about the systems of the body and we're going to work through system by system. So ask about all the appropriate systems, be it the respiratory system, the circulatory system, the neurological system, and so on. We also look at the past medical history, including their medication and family history and social history. So quite a comprehensive system to follow through and to document. And this is all leading up to our handover. So even right at the beginning of our patient assessment, think about your handover, because the next clinician could come in at any time and we want to hand over appropriately to them. The JR Calc recommends that the patient handover given to the receiving clinician is the ATMIST format. So we're just going to finish off this session by going through the ATMIST handover tool. Some people refer to it as NatMist and put an N in front, and they also give the patient's name, which I think is a really nice idea, but we're going to give the patient's age, and then relevant informations such as relevant timings of the incident and appropriate timings, the mechanism, so the MOI, what happened, any injuries or illnesses that we have discovered as doing our primary and secondary survey, and include relevant signs and symptoms, and finally any treatment that we've given or immediate needs that the patient needs that we wasn't able to treat. Keep your handover short and sweet. Keep it to the point. And the easiest and best way to do this is to write it down as you go along. Then when the clinician comes in, you can easily give them a quick ATMIST handover. Remembering the new clinician that come in is already started their own primary survey whilst they're talking to you, and they want to start their secondary survey. So, in conclusion, that stepwise approach is full of lots of different mnemonics, but it is the best way to achieve the 3 Ps and get the best outcome for our patients. Lots for you to remember, and you can't remember this all. So do yourself a favour and get yourself a good aid memoir, whether that's using the Pocket Guide JR Calc and carrying that around with you and using it appropriately, or designing your own aid memoir, something like this, which will go through all them different sections that we've just talked about. In all fairness, this aid memoir we can see on the front should be learnt before you come across a patient, because you need to flow quite quickly. But on the back of this would be an appropriate aid memoir for our conscious patients with their presenting complaint. So I've come to the end of the video now, and it's come to the 3 pages of the glossary, so I'll leave each of them up here for a few seconds. But whilst you're having a look at that, just a reminder, if you have enjoyed this learning session, please hit the thumbs up button down below, and don't forget to pass this video on to other people who may find it of benefit. If you do have any videos you would like us to make, then please leave us a comment in the link below. I'll just click through those last couple of glossaries for you, but you can always pause this and come back to it. I look forward to seeing you on the next 2 videos. So the next one is to do with our unconscious patient and practically going through this stepwise approach, and the 3rd and final patient will be the conscious patient that we're going to follow the stepwise approach for. Thank you, and we'll see you on the next video.